Good morning, everybody. We are so happy to have so many attendees today at PVI course 2025. How are you today, Kun?
I'm feeling good right at the moment, honestly spoken. So it's a pleasure to open this PVI together with you, to open the first session. It is, by the way, not the official opening. So at 10:30 this morning, here in Le Nôtre auditorium, we will have the official ouverture ceremony. So be here, please. But let's start first scientifically.
Right, we start with the first session. It's about endovascular myth to separate fact and fiction. And so I call the first speaker, Michael Richman, about CERAB or kissing for iliac disease. Don't forget that PVI is based on interaction. So if you have questions, ask your question. Go ahead.
Good morning,
It's
Jan.
a start for 3 days of debate and communication.
Thank you, Jan. Thank you, Koen. It's a pleasure to be here, an honor to be the first speaker at this wonderful symposium, even before the opening. All right. So these are my disclosures. When we talk about aortoiliac occlusive disease, traditionally these patients were always treated with kissing stents from the 19th already. And these results were quite mixed. We did a meta-analysis on patients. That study included 600 patients, of which half were treated for relatively easy task EMB lesions. Most of these patients were intermittent claudication patients, but then you get a primary pediatry at 2 years of 81%. And when you look at other literature, and you look at failures of kissing stents, it's often related to geometrical mismatch. And that can be caused by a variety of causes. But what's important to realize is that the kissing stent configuration per se does not exist. And often we are comparing apples and oranges. So it depends. Are you using self-expanding stents or balloon expandable stents? Covered stents versus bare stents, crossing or not crossing stents. The amount of stent protrusion in the infrarenal aorta is of importance. And you can also flare the proximal part. And this is an image from a colleague from Japan who even made double Ds in kissing stents. And you can imagine that this is a completely different geometry when compared to stents just in the distal aorta. So the covered endovascular reconstruction of the aortic bifurcation was introduced by Peter Goverde a long time ago already. And the goal was to get a more geometric reconstruction of the aortic bifurcation. And with that, to get a more physiological flow through the system, to avoid these disturbances by flow. There are a few aspects that are very important. The best geography you get when you use a 12 millimeter aortic cuff with 2 8 millimeter limbs in the iliac arteries. That gives you the lowest radial mismatch and the low disturbances of the flow. Then obviously appropriate flaring is essential to get a good apposition both proximally and distally. And these balloon expandable cover stents you can flare all the way to 16 or even 18 millimeters. And it's important to treat all diseased artery. So go all the way to the distal external if needed. Do an anti-attractive to the common femoral artery when the outflow is disturbed. Make sure that you have a good outflow. This is some images from a flow study that we've done in the past. We compared the CERAB configuration with both bare metal but also balloon expandable kissing stent. And what we saw right here, you see a large area of flow disturbances in the kissing covered stents at the inflow. And when you look at the bare metal kissing stent, you see it at the native bifurcation. And there have been some post-mortem studies that show that exactly at this area in patients with kissing stents, there are intermittent neohypoplasia and restenosis. So this is an area of concern. So what do we know about the data? We've published our first series together with Peter at 2015 already. And during the years, other countries and other studies have been published. And you see that the results are very comparable. There's a primary patency at 1 year between 87% and 95%, and a secondary patency from 95 to 100% at 1 year. And in a group that are mostly task C or D lesions.
Michael?
Yes?
I didn't see any control group here in this amazing results. So I should ask to my English colleague, you know, we have an English corner here, very dedicated about study. Are you convinced by this single registry data about cover stent?
Well, all forms of registry data will actually have some limitations, right? And the limitations are that we report the better or the easier cases, right? So you could argue that in any case, you need the randomized data, but that's not out there. It will hopefully be out there in the next few years. But this is the best data we've got for the time being, albeit with limitations, yeah.
Yeah, I fully agree with that. We need randomized data. I've been trying to set up a randomized trial of kissing stent ferrous share, but it's very hard to do. The sample sizes are huge, and it's hard to make to select the right patients for such a study. Makes it difficult. Yeah. Another thing is, these are only 1 year data, and these patients are often very young, or relatively young. So we need long-term data. Unfortunately, we have them now. These are our own data set. From 2010 to 2020, we have treated 160 patients with this technique. They were aged 62, and you see about 0.5% of our females. Interestingly, about 28% of them were treated before in the area that we treated with syrup. And when you look, 24% were CLTI. So we're not really the easy cases, particularly since 83% had TAS D lesions. But nevertheless, we get a 96% technical success rate. And it's important to realize these were from the first patient that we did, so not a single patient was excluded for this analysis. When you look at the clinical outcomes through 5 years, you see that immediately after the procedure, the Rutherford increases to normalized in most patients, and it remains rather stable during the first 5 years after treatment. And you see the same in the ankle brachial AIOD, normalizes and stays the same. And this is what we are used to looking at, patency rates and TLR rates. At 5 years, the primary patency rate is 78%, with an assisted primary patency rate of 88% and a secondary patency rate of 95%. And this reflects in the freedom from clinically driven TLR of 84%. When you look at the clinical improvements, an improvement in Rutherford category at 5 years was achieved in 98% of patients, so the clinical results are excellent, and we did not do a major amputation in a single one of them. Keep in mind, 25% had CLTI before treatment. Then we also looked at those patients that had a primary syrup compared to those that were treated before in this area, and there were significant differences, and we didn't expect them to be that big. But when you look at patients that were not treated before in that area, they had at 5 years a primary patency rate at 85%, an assisted primary patency of 94%, and a secondary patency of 97%. And when you compare this to the literature on open surgery at 5 years, it's very close to what had been published before, particularly since our definitions of patency are much stricter than those with open surgery. To get more robust data on subgroups, we also performed an individual patent data meta-analysis. We were able to get 6 data sets of the previously mentioned studies, 412 patients. You see the 5-year patency rates are similar to our own results. And when we looked at the predictors for loss of primary patency, it were particularly patients with a younger age, patients that were treated for CLTI, and patients that had a history of prior target area revascularization. So those patients need to be monitored very closely, and you may debate if the others need very strict follow-up or not. So often people say, well, you do it only for easy lesions. You can also do for very complex lesions. So this relatively young lady with a real Leriche all the way to renal arteries. You see the angio, where you see two nice renal arteries with an occlusion flux below it. What we did in this case, we put 2 balloons in the renal arteries. We performed a syrup, and you can see that you have a very good result here. This patient now has 4-year follow-up without any problems.
So, Michel, sorry to interrupt here. Yeah. I'm here. You know, I'm an endovascular-oriented vascular surgeon. Mm-hmm. If there is in the iliacs, aortoiliac occlusive disease, one indication for me for open surgery, it is this flush occlusion up to the renals. The risks of distal embolization, not only during your CRAP procedure, but during the recanalization in mesenteric, can create catastrophes, as you know. So who wants to comment on this? Is this also your opinion, or I'm a scary, poor vascular surgeon, and I miss the courage to do this with C-wraps. Who is doing this flush occlusions aorta still open? So you see, I'm not the only scary one.
You're not the only one, no.
And what are the reasons? Can somebody comment why you are doing this open? Thanos? Can you have the microphone to our UK friend? Meanwhile, are there some other comments? Yes, also there.
Pirkka Vikatmaa, Helsinki. The Swedish introduced to us, specifically from Uppsala, that they do 12-hour thrombolysis even for chronic occlusions like this. And after that, I think we haven't done a single open anymore. But the thrombolysis opens it so much that then you can do more safely the C-rub.
Yeah, I'm happy that you say that. We do these cases. We have done them. Our experience is good, but I also know these comments and how people think it could be. We're now analyzing a series of juxtarenal syrups together with a group from the UK. And there's various strategies you can use. You can use protection balloons. You can do 24 hours of thrombolysis. We've done that before, sometimes with success, other times without success. And sometimes you need chimneys in the renals. And the question is when to do what, including open surgery. And that's the question that's still open. We don't do a lot of open surgery anymore, but I don't say that I never do it anymore. So it's still something you need to know.
Thanos?
I think generally in medicine, and I told that to Michelle on the way here this morning, or Costas, you can never say never, right?
Exactly.
But from EVOC, and we've now got about 270 patients, there are 3 cases where we've really had issues with filling in the serious adverse events stuff. And of course, I'm blinded, but these 3 cases had all chimneys in them, and the patients have died because of complications due to the chimneys in the renal arteries. So I've become extremely cautious with that.
Yeah. Maybe I can show you this immediately. This is the data that's available on chimneys and syrup. It's not a lot, but it's a case series, 14 patients. Half of them had chimneys in the renals. Technical success was high, mortality was low, and the patency rate of the chimney is 93% at 1 year. So it's not too bad.
Yes, sorry, Koen Kersen. I could totally agree that there are different opinions and in the worst case patients, but I share my friend's scare. Also, we have to realize when we give thrombolysis, and I'm very pro thrombolysis, in chronic occlusions, we have to realize the thrombolysis agent will only resolve the acute part. I'm a little bit scared when we have these patients, which will be very sick in general, to give them 24-hour thrombolysis on a chronic occlusion. I mean, you have high complications for cerebral hemorrhage, other problems. So
I agree. You know, we did it a few
times. We can do it. I know we can do it, but still.
And the reason I stopped doing it and prefer renal balloons is that we had a case that had massive microemboli into the renals through the thrombolysis with the renal function decline. So it's not without risk. So is syrup then the final solution? No, absolutely not. There's still some technical challenges. Some people do not really know how to do it, and that results in these kind of images where a 60mm stent is used with 2 aids, and then you still see some weird flow figures, and obviously they will lead to problems. Flaring is still outside the IFU. We want to treat our patients inside the IFU, so we need a device to become into the IFU. How about to deal with larger aortic diameters? Well, the AFX has been used. There's been some publication on that. And how about future crossover interventions? So we dedicated devices absolutely needed for AIOD. So work is to be done by the companies. I think this one is important as well. When to use it, this is my personal opinion. I think there's still room for open surgery, for kissing stents, and for syrup. So when you have a short protrusion in the distal aorta, so 1 centimeter or so, then I use kissing stents. Going higher up, I use syrup. When you go to the renals, in the fit patients, I prefer open surgery. When patients not fit for surgery, use either protection balloons or chimneys. So to summarize, the clinical and technical outcomes of syrup are good through 5-year follow-up, and it can also be performed safely in the extrarenal pathology. Previous treatment in the tract, CLTI, and a younger age are independent risk factors for loss of primary patency, so these patients need to be monitored. We need comparative trials with other techniques, and there's still no final answer. There's a role for all three technologies, and we need to make the right choice depending on your capabilities, the experience of a center, and the evidence. Thanks a lot.
Thank you very much, Michel. Great overview, very practical. Thank you. So a lot more to discuss, but unfortunately we are a little bit restricted in time, and we move already to another very controversial topic. Hani Zayed from London will offer us, hopefully, a solution there. We know that the ESVS guidelines 2024 were updated with an important part on the common femoral artery. So for you, Hani, and explain us to the audience, to the PVI audience, are these guidelines well deserved over there? Are they too strict? Or do we need even more liberal guidelines? What is your opinion?
Koen, that's a tough ask, I have to say. It's always a great pleasure to be here. And I've been given this controversial task, sort of whether the guidelines for common femoral arteries are enough or not. So why is it the common femoral artery is always an area, or a very contentious area? This is because it's like the gate for two roads. It's the gateway to both Profunda and SFA. And before just getting a sort of overview, I thought let's just check what is the ESVS guidelines. So there are three major recommendations. The first one is that if you have a common femoral artery stenosis or occlusion not extending to the bifurcation, so in the main trunk of the common femoral artery, endovascular treatment may be considered. The next recommendation is that if you have a low-risk groin, and you can define low-risk groin as you wish, and you have a common femoral artery disease extending to the bifurcation, then open surgery is the recommended approach. But on the situation where you have a hostile groin, it doesn't matter how extensive the disease is, this is when endovascular is recommended. Whether we agree or not agree, this is far more sort of liberal compared to the SVS guidelines, where it blankly says open or endarterectomy with a patch is the first-line treatment. So in order to be able to assess the guidelines or objectively judge the guidelines, I thought we have to answer three questions. The first one is actually how many of our patients would be suitable for both options, because some of them will be just suitable for open, not endo. Also, is open really the gold standard? Is it the sort of faultless procedure? And why do we actually change? I'm a surgeon, and the surgeons in the room, we've been trained to do endarterectomy. We like it, it works. So why do we change? And the last thing is, the alternative, the endo, if we're offering endo as an alternative, is it a valid and durable option or not? To start with the first question, how many of our patients are suitable for both? A couple of years ago, we looked at our femoral endarterectomy patient retrospectively in two main centers in the UK over a 4-year period. What we wanted to look at is the anatomical distribution of the disease. How many of them would fall into this focal disease, and how many of them present with disease extending to the bifurcation? And we used this famous classification published previously by Jan and his group, which is the Azima classification, sort of A, B, and C. We also wanted to look at the structure and the composition of the plaque, because we know the higher calcium composition of the graft, or component of the graft, of the plaque, this is very unlikely to respond to just vessel preparation, and most likely will need stenting. And this is something which we reported before. And using the TerraRecon and the plaque analysis module, you can get information about the plaque volume, the plaque composition, and also the absolute and proportional volume of calcium within the plaque. So what did we come up with? We managed to recruit 829 femoral endarterectomy patients, which is a good number, so you can actually get some meaningful data from it. The vast majority were men, and 2/3 were CLTI. So this is the type of operations and patient that we deal with. And we followed them up for almost 5 years. When we come to the anatomical distribution, we were surprised to find that 10% of them were class A, which is perfect for endovascular, 25% with class B, which is also a good solution for endovascular. So effectively, thirds of our patients who ended up with endarterectomy could have been considered for endovascular treatment. The 65% were the type where the disease extends to the bifurcation. But does this mean that they were not candidate for endovascular treatments? We went into it and we digged deeper into the anatomy, and we considered that they could have been considered for endovascular treatments if they had a patent external iliac, stenosis rather than occlusion of the plaque, and then at least one run-off vessel. And if you include this criteria, 85% of the patients who ended up with endarterectomy could have been considered for endovascular treatment. So the consensus that no, patients are not suitable for endovascular treatment, I think this is something that we need to revisit. When we looked at the plaque composition as well, 2/3 of them did not have excessive calcification that you would say they will end up with a stent. So with the availability of the new vessel preparation techniques like IVL or atherectomy, 2/3 of these patients are likely to end up without stenting in this area, which is the big sort of scare for most of the interventionists. So in summary, from this study, 85% could have been considered for endovascular treatment, and actually we don't need to worry that much about stenting because only 1/3 of them might end up with a stent. I think when we come to the next question, what about femoral endarterectomy? I said sort of the conflict of interest is that I'm a surgeon and I like femoral endarterectomy, but is it really a faultless procedure? Do we not have any complications from it or not? I would like to bring to your attention this study, which is the GIFT study, which is effectively a prospective registry for 1,337 vascular groin incisions in 37 centers. And the fact that it's 37 centers, you can't say that this center is very poor technically, and that's why the complication rate is high. It's very widely distributed. So what was the outcome? More than 8% had groin infection. 4% had severe surgical site infection requiring surgery, like abscess, hematoma, collection, and so on. And those who had surgical site infection had significantly longer hospital stay, and you talk about the costs here. And those also who had surgical site infection had significantly higher incidence of acute kidney injury. And look at the risk factor for surgical site infection. These are the ones. And if you look at the middle four, you will probably see that these are the standard profile of a typical vascular patient. Diabetics of ischemic heart disease, overweight potentially, and most of us use patches, whether bovine or prosthetic. And was that unique? Actually, this exactly was what we found as well in our CONFESS study. 8% of those patients had groin infection. So it's not a unique thing. You will have almost 1 in 10 who has groin infection after femoral endarterectomy. The last question, is endo a valid or durable option? And personally, I think this is where we as a vascular community are failing to prove. Despite the fact we like it, we love it, and we see the potential, but we fail to prove it. Why is that? Because it's still now, it's up to this man who conducted this study, who or managed to deliver probably the only good quality randomized controlled trial comparing stenting versus endarterectomy. And I'm stressing on the fact that it's stenting. It's not necessarily just endovascular, it's stenting versus endarterectomy. The main outcome or primary outcome was morbidity and mortality at 30 days, and there was also a long list of secondary outcomes. So when we look at the two groups, they were actually well matched. There was no significant difference. No group was worse than the other. But when you look at the primary outcome, stenting was significantly better than endarterectomy in the early 30 days morbidity and mortality, which is something you would expect. But I guess you'll ask, how durable is that? And when they looked at the data at 2 years, there was no significant difference between stenting versus endarterectomy when it comes to freedom from TLR, freedom from target extremity revascularization, overall survival, or patency. So it works. But apart from this effort, there are loads of retrospective, sort of multi-center or single-center data, and hopefully we'll do something with Nasr as well for some risk. But all of that, non-randomizations. So where are we going now? we're desperate to wait for the results from the SuperSurge RCT, which is run by this smart, handsome young man as well.
Long time ago. Long time ago.
And effectively, this again is comparing stenting using the superior stent versus endarterectomy. And the follow-up will be significant, like 3 years, which is something which is important as well. But till now, we have significant limitations. So when we come and talk about stenting, we actually use the things which are not designed. As Michel mentioned earlier, for the syrup, you're using things outside the IFUs. And the stents, even when we use it, there is no stent which is properly dedicated to the common femoral artery. It doesn't take into account the anatomical features, the bifurcation, the extrinsic mechanical and bending forces as well. And as if what we're trying to do is to come and change a gold standard, something we know that it works, with something else because it has wheels. This doesn't work. What we have to do is find a proper, dedicated, well-designed, purpose-built stent to fill in this gap. But the message from this talk, if I may just focus on one thing, is that we have to change our thinking. So endovascular treatment of the common femoral artery does not necessarily mean stenting of the common femoral artery, especially in the presence of these new vessel preparation modalities. And because of that, the third handsome guy, Thanos Saratsis, who was just talking earlier, and he's in the room, we managed to get funding for a randomized controlled trial, pragmatic one, looking at the clinical and cost effectiveness of endovascular as a whole, whether you use stent or not, vessel preparation or not, atherectomy or not, DCB or not, versus femoral endarterectomy. So in conclusion, talking about the ESVS guidelines, I think I would call it's a pragmatic conservatism. So to some extent, they acknowledge the fact that the endo has a role, but I think if we were to try to change the recommendation, we have to help them by, first of all, working on the material that we use to make it purpose-built, well-designed to fit in this anatomical area, but also we have to provide level 1 bulletproof evidence to support the change in the recommendation. And finally, endovascular treatment of the common femoral artery does not necessarily mean stenting. And thank you for your attention.
Thank you very much. Thank you very much, Shani. So I know that we have mainly a surgical audience, vascular surgery audience. So after your talk, I would like to know who is, as a vascular surgeon, who is open for this endovascular approach in the common femoral artery, right at the moment. So you see, step by step, but to your point, and I also would like to ask the audience comments and Jan's comment to your opinion. Endovascular approach, what does it mean actually? Because we know we have several. We have and that's a little bit the problem with Thanos' study. So we're gonna put again all the endo stuff, angioplasty, lithotripsy, specialty balloons, stents, whatever, all in one pot, and then to finalize at the end say, look, endo is not so good as open.
Yeah.
Which endo?
So
That's the question.
I think
probably first we need to ask the audience. Random. Which endo? Maxime, if you prefer to do an endovascular treatment of your common femoral artery, what do you prefer?
I would also always prefer to stent it.
Okay, so we can ask also to a cardiologist in New York. Yes. Prakash, what do you do when you do endo?
Generally, we do IVUS.
Microphone.
Evaluate the plaque.
Microphone.
So generally, we do IVUS to evaluate the plaque. If it's calcified plaque, then we'll do some sort of plaque modification, whether it's lithotripsy or atherectomy, and followed by a drug-coated balloon, appropriately sized.
More comments from the audience on this? Are there some alternatives that we are missing? Lithotripsy, atherectomy, there? Yes, please.
Hi, James Tunnicliffe from Cape Town. So I trained in the open surgical era, and the one thing that we learned was that the most important thing you do when you do a femoral endarterectomy is to make sure that you treat the profunda with great respect. There was a lot of publication, probably before most of you were born, about the importance of the profunda as the main saving artery of the limb. My concern with endovascular therapy is that it is tricky to do that, firstly. And secondly, the durability of the profunda patency doesn't seem to be listed in many of these articles about this. So the first question is, can you comment on that? And the second is, we very rarely see isolated unilateral femoral disease. And if you're going to do a crossover approach for this endovascular therapy, you run the risk of causing problems on the otherwise asymptomatic side. Could you comment on that as well?
Sure. So I'll start with your second point. When we say rarely see isolated common femoral disease, we actually looked at what we find. And 35% of patients will have isolated common femoral artery disease. So this is 1 in 3. So it's not a small group of patients. When we come to the profunda, yes, I get the concern, and this is something that we always care about as surgeons. But this doesn't mean that there is no endovascular solution for it. And with the new technology, I think if we take away the concept that stenting is a must, with the new technology, you can still treat profunda osteal stenosis with all the vessel prep techniques and then DCB it if you want. Because you don't have to put a stent in every endovascular treatment of the common femoral artery.
Stenting is a subject, not just for CFA, but also for distal popliteal artery. So I call now Sabine Steiner. Thank you so much, Annie. Thank you so much. And I call Sabine Steiner to discuss more about this no-stenting zone. I don't know what is it really, no-stenting zone, Sabine. What is a non-stenting zone?
You gave me the title, Jan. Thank you very much. Let's see what I find out. Can I have my slides? First, thanks to the organizers. First point to make, I'm the first one who is using the official PVI slide set. So just to highlight this one here.
Thank you very much for that.
Thank you very much. So it's about distal popliteal disease, similar but not the same is the way I want to start with 2 patients I saw and treated recently. So the first one is a male patient, 70 years old, type 1 diabetic for decades now. Importantly, in parallel, he suffered from unstable coronary artery disease, needing really complex PCI, and had a non-healing wound with massive rest pain after a minor amputation on the left side. The other one is a relatively young male, massively obese, 130 kilograms. He was super happy he lost 20 kilograms due to GLP-1 agonist treatment, but still on hemodialysis 3 times a week, diabetic, contralateral, major amputation. This was his only foot left, and a non-healing wound after minor amputation also on the right side a few weeks ago. And this is how they present it. So it's distal popliteal disease with a P2-3 occlusion, and for the relatively young dialysis patient also involving the trifurcation. And I think when we talk about distal popliteal disease, we have to understand what we treat with respect to the lesion as always, but especially in this area, because there are really challenges. And I think bridging this gap, this popliteal to tibial CTOs, this distal popliteal disease, is a challenge in crossing. It's a challenge in avoiding and stabilization of recurl in dissection, and it's a challenge in maintaining patency. And this is because we have some distinct features for distal popliteal disease. So there's a larger variety of underlying pathologies that we might see normally in the FemPop segment. So of course, atherosclerosis is the major player, but we also find fresh and old embolic occlusions there. Aneurysmatic disease, of course, has to be ruled out before, or at least we have to know about it when we do endovascular interventions. And there are also rare causes like post-surgical cystic adventitia or entrapment syndromes. And it's also the presentation of the disease can have a lot of heterogeneity with respect to lesion length, location, calcification, distal outflow. Of course, I think that's the main part of this talk. What about the P3 segment as the highly mobile segment? And of course, what about BTK trifurcation involvement? And when we go to these two patients, I think when we look at these lesions a little bit more closely, you see the specific issues. The first patient, there was really a rock in the P2-3 segment, necessitating retrograde access, and you see with the two wires just moving around this rock here, while the other patients involving the trifurcation, the calcification in the popliteal artery, in the anterior tibial artery, was mostly medial, not so prominent, but in the tibiofibular trunk there was a more intimal plus medial calcification. This really has major impact how you can treat, I think, these lesions and if you will need stents or not. And this is the question, what treatment options do we have and which kind of data do we have for these treatment options? And also thanks to Hani and others, there's a registry out there of a multi-center retrospective registry of 651 consecutive patients treated for isolated popliteal disease. And they were treated in various centers, 15 centers in Europe with various treatment modalities. So of course it's non-randomized data. PTA, drug-coated balloon, low chronic outward force stent, high COF stent, atherectomy, and directional atherectomy plus DCB. When you look to the involvement of the P3 segment, actually it's quite a minority that the P3 segment was included here. So P2, P3, what I've showed you was about 9%, P3 only 6%. So the numbers are really small for the subgroup. But overall, their statements of this analysis of this registry is that the whole cohort actually showed quite a good primary patency after the median follow-up of 26 months, which was 74%. POBA, so just standard balloon angioplasty, was seen as marginally inferior with respect to freedom from TLR compared to the other treatment modalities. And I think this is what we know, the predictors of reintervention, and it's really nicely highlighted here again, popliteal occlusion and poor runoff status. So what do we have for studies for popliteal stenting? This is a very nice, actually Austrian-French collaboration of Stephanie Rassam and Raphael Koskas that has been recently published, just looking at the data which is out there, and it's not so much if you look at the time frame, which is now about over 10 years. And there's only, as we know, one randomized controlled trial by Losha Rastan, the ETAP trial comparing the live stent versus PTA plus bailout stenting. So, and also the stent options. Actually, we talked a lot of being outside the IFU. When we talk about distal popliteal stenting, P3 segment, almost all the time when we use most stents, just the live stent also has an IFU for the entire popliteal. We are also outside the IFU here. So it's really hard to make comparisons and any recommendations, but I think this is a little bit what most people would look at, 12-month primary patency from the live stent in the ETAP trial versus Sopera, maybe versus Tigris, is also a vasculomimetic stent. Sopera seems to have good data here. I think this is one of the reasons why many people use Sopera if needed in the P3 segment, and also due, of course, to the low fracture rate. But the problem is it's mostly not just the P3 segment, and this is really this dissecting into the trifurcation. What are you going to do there? Because, and this is the difficult part of it, you have this diameter mismatch. I mean, the Sopera in the distal popliteal, I like it. Maybe not based that well on data, but on experience of many of us and some registry data out there. But how do you proceed further down? Small Sopera, balloon expandable, drug-eluting, self-expandable BBMS, DES, of course, bioresorbable scaffolds. I think you have to be very, very careful. This case was solved with a Sopera. But should we implant here balloon expandable DES? We have seen over the last years really quite some crushes of DES because the Sopera stent is moving quite a lot. So I don't think there's an optimal solution. It should be, for me at least, to keep distal popliteal stenting, keep it to a minimum. So for the first case with this rock in the P2 segment, I was sure we will need a stent. So it's about a good wire passage. It's about very good ballooning with non-compliant high-pressure balloons. And this is the result you get after ballooning with a 7-millimeter balloon in here, massive recoil, superior stent implantation, and I think quite a good result for this lesion. And of course, no troubles with the distal outflow. For the other patient, I think there is a chance that we can avoid stents. So the first intervention was IVL into the anterior tibial artery. Due to the obesity, I had first a crossover approach, which was difficult. So a second antegrade approach, orbital atherectomy, and a very good result as well here. There's a recommendation from this paper that intraluminal subintimal crossing could play a role, how you address these patients. But I think overall, it's just as a summary, we have to address the high heterogeneity of pathologies and anatomical complexity. And this is how we have to tailor our interventional strategy. Vasculomimetic stents are available, low fracture rates, but of course, comparative effectiveness data are still limited. Thank you very much.
Thank you very much, Sabine. We were even unable to interrupt you because of the high quality of your presentation. But to compensate this, we're going to ask you very difficult questions. Please, audience, do you have questions in this very difficult area, P3, P2, how to handle it? Please, Erik.
Thank you for your nice presentation. So in your hands, which stent is now the best to put in a popliteal artery with the lowest risk of fracture and re-occlusion?
In your hand.
The one I don't need. It really depends on the segment. Honestly, for the P1 segment, this fem-pop distal stenting, what we do quite often, if you don't have massive calcification in there, and after ballooning, of course, you might have dissection and so on, but if you feel confident that you can go with a standard self-expandable stent, probably drug-eluting stent, I would say so, I feel very comfortable to do a standard stenting with a drug-eluting stent there. P2, P3, as I've shown you, is really, really difficult. So it's really, especially if you go down P3, it's about the outflow and the trifurcation. For me, it's typically a superior stent after optimal predilatation in calcified lesions. But if I don't have a rock, as in this first case, in there, I really try to stay intraluminal and maybe try to avoid stent by optimal lesion prep with various devices.
You try to avoid stenting, Sabine. So does it mean that you spend even more time on vessel prep, using more tools, more expensive tools, everything to avoid stenting in this area?
Well, you know, rich countries, poor countries. No, yes, I think the most important step is to stay intraluminal, and therefore you need very often retrograde access, so a very low threshold. Even in the first case where I knew I will need a stent, retrograde access just ensures that you're not dissecting down. And if there's one area you don't want to dissect down beyond your CTO, it's definitely the P3 segment. So I think this is the main part.
More burning questions? Yes, please.
Yeah, Helsinki again. This is an area of sometimes an equipoise where you say that you can do it endovascular, you can do open surgery. Last weekend I did 2, and after 5 hours of doing lithotripsy and whatever, I thought that the patient had a single segment and there was quite a good runoff to start with, so I maybe should have done a bypass in one of them. Do you think that there's situations where the patient would benefit from the bypass as they are staying in the best CLI study?
Absolutely. I think a bypass is a fantastic option. Honestly, the first patient presented with unstable coronary artery disease. Even after our intervention, he had to go to the ICU for a couple of hours because he was so unstable. The second patient was 57 years old, 130 kilograms. I couldn't even, in an antegrade approach, puncture the common femoral. I had to puncture the proximal SFA because he was so massively obese. So, of course, you could do a distal bypass, but it's really for the long-term outcome. I think it's important not to burn down any distal bypass landing zone, and I think in both cases we didn't do so. So you keep this option alive, but this is the critical point of it. If you go into troubles during your intervention and you feel you're kind of dissecting further down, I think this is the point where you have to stop and re-evaluate for the bypass surgery. But as I've said before, both candidates I think were not ideal for bypass surgery.
Thank you very much, Sabine. Thank you. I see some people standing there in the back. Please take your seats over here. You know, varicose veins is a real problem. So, very good. So having said that, it's my great pleasure and honor to introduce one of our Swedish friends, Per Skog from the department of Joachim Nordanstig, one of the PIs of the SWEDEPAD. Joachim was not so brave to walk here on the catwalk, so you are replacing him in a fantastic way. Please, can you translate the SWEDEPAD findings into our daily clinical practice, Per? Please.
I'll try. Thank you very much. Lovely to be here, and thanks to the organizations. Lessons from the SWEDEPAD trials. Maybe I'll kill a darling for you. I have no disclosures. Well, having a case here, not a very uncommon CLTI patient. You have massive atherosclerosis in the fempop and the popliteal segments, and a single vessel runoff. We had this case last Thursday. What to do? Well, there is a lot of options. And you can use POBA or drugs or stents, different kind of stents or bypass. Well, we performed the SWEDEPAD trial. It's actually two trials. It's RCTs. They are embedded in our national vascular registry that covers almost all vascular interventions in Sweden. And the objective was to investigate the effectiveness of drug-coated balloons and stents. The SWEDEPAD 1 was in CLTI patients, and the SWEDEPAD 2 was in claudicants. And we have patient outcomes, centered outcomes, with major amputation rate and quality of life for the claudicants. And we also have a lot of secondary endpoints, explorative. Well, this is a robust RCT performed according to all the recommendations. And we have 2,400 CLTI patients, 1,300 claudicants allocated and randomized to either drug-coated devices, stent or balloons, according to the surgeon, or uncoated devices. And we had primary endpoints different for the two categories of patients. And the SWEDEPAD 1, the CLTI study, we have a very good randomization. The groups were well balanced and they mimic the everyday Swedish CLTA patient. The primary endpoint, we didn't see any difference in major amputation at follow-up 1 to 5 years. There was comparable or amputation rates with other studies, but no difference. The secondary endpoint, we didn't see any difference in all-cause mortality in the SWEDEPAD 1 study. However, we saw that we delayed the target vessel reintervention rate during the first rate in the coated group. But the uncoated and the coated were the same the second year, so we didn't prevent. However, if you look at the worst patient, the Rutherford 5 and 6, we had an increased amputation rate in the drug-coated group at the 3 month. SWEDEPAD 2, the claudicants. We have there as well a very balanced randomization They mimic the Swedish claudicants accepted for endovascular intervention. And there was quality of life at 1 year, and there was no difference between drug-coated or uncoated devices. Secondary endpoints, we didn't see any difference in target vessel reintervention between the groups. And we didn't see any all-cause mortality difference in the total follow-up in 7 years. However, after 5 years, there was a significant increased mortality in the drug-coated group. You shouldn't exaggerate the mortality signal. However, it's in line with Katsanos, but it's very small numbers. But it's a randomized trial, and it's huge, so we get significant result. So our conclusions with the SWEDEPAD 1 and 2, it didn't, if you used drug-covered devices, it does not reduce amputations in CLTA patients. You do not improve quality of life in claudicants. And you delay reintervention the first year with drug, but you also have a signal of increased 5-year mortality in claudicants.
So probably it's nice to have this slide with these 4 debatable statements, I would say. So to go over these with our audience, with our esteemed audience. So we all know, we are, during all international congresses here, we are talking about the fantastic paclitaxel-coated balloon trials. All companies are supporting crazy randomized controlled trials, global studies, real registries, whatever, showing every time the most fantastic effects of the paclitaxel-coated devices, and in balloons and in stents, and now we have this. So I would like to comment on the audience, on some of the... So what do you think about, let's focus first SWEDEPAD 2. It doesn't improve the quality of life of our claudicants. So do we need still to treat with paclitaxel-coated devices? There, Peter Schneider.
Thanks, Jan. Thanks for inviting the question. Yeah, this was a major undertaking, and I think it's really important that these efforts go forward, but I don't agree with any of these 4. I don't think these are conclusions. These are maybe possibly directional type activities. So this was a randomized trial going in, but really it was a community-based effort after that. In-person visit only at 1 year. So this does not have the bells and whistles of the randomized trials the way we think of it, like the BEST CLI, like the Basel 2 and 3. It's, again, randomized going in, but in the long-term follow-up, it doesn't have the same veracity. And I'll give you an example. So one thing I learned in studying the mortality issue was that the 2 biggest faults of Katsanos and also of the randomized trials that had been part of the meta-analysis in the US was the crossovers and the loss to follow-ups. Neither the crossovers nor the loss to follow-ups were dealt with. When those were identified, found, adjudicated, the mortality signal went away. Second thing, how can you have a toxic substance that kills people at 5 years but not at 1, 2, 3, 4, 6, 7 years? It doesn't make any sense. So if the paclitaxel had shown better mortality, we wouldn't say that paclitaxel saves lives when it was just at a 1-year time frame. So I think this is a misinterpretation, just personally. Again, it's a massive effort. I think the world is better with it than without it, this study. But I don't think it was powered for mortality. And then just last, I know I want to stop here, but last thing, there was no signal in SWEDEPAD 1 for mortality, but there were more patients in 5-year follow-up than there were in SWEDEPAD 2, where there was a 5-year signal. So to me, it doesn't make sense. It doesn't pass the test of common sense.
There was a lot of questions. I tried to answer them. When we do the per protocol analysis, the mortality signal increases, so the crossovers are dealt with. The loss to follow-up are not dealt with. We haven't interviewed them or caught them, but we have pretty much the same number in both arms, and the groups treated are very well in line with the people treated for CLTI or claudication in Sweden, because we have the registry to compare with. And then there was another question in the end.
How can something hurt you at 5 years, but not at 1, 2, 3, 4, and 6, and 7 years?
Yeah, and I don't have the answer for that. However, if you focus on the mortality signal, well, that's explorative, and it wasn't powered for that. But the main effect is lacking. And I'm a tax-financed surgeon. I don't get paid for what I put into people, but I have to be conscious when I use taxpayers' money, and they are very, very expensive in Sweden. So
yeah, the study was designed perhaps in 2014.
Yeah.
Yeah, a long time ago. At this period, we have few devices, in fact, available, including drug-eluting devices. Do you think that the concept, it is a concept of SWEDEPAD, is a concept of, of a class effect? It means that all devices, in terms of bear, in terms of eluting, are the same. Since this period, we have different studies regarding long lesion, short lesion, and we see some difference between just balloon and stent, for example. We see also some difference between some drug-eluting devices. Do you still believe in this concept of class effect between all these devices?
Well, we haven't yet studied the class effect. We have ongoing studies, but it's over 3,000 patients. And you can read the publications. They are well mimicking the ordinary common patient. There is short lesions and there are long lesions. And the sum of it is presented there. So we'll come back with the class effect.
Okay.
There is a question of Sabine.
Thank you very much. Here, I have a burning question, to be honest, since I've read these publications, and I'm more than happy to ask it. So you used Vascular 6 as quality of life, and we know it's very well validated also by the Swedish colleagues. And the baseline value in the claudication group was 10 at baseline and 10 in the CLTI group. So both groups, CLTI and claudicants, had the identical quality of life at baseline. And I just don't understand why this Vascular 6 can't differentiate between claudicants and CLTI. It questions for me a little bit the validity in this trial, to be honest.
Well, what people believe are quality in their lives is very hard to get. However, I say that the randomization is the key, because some CLTI patients may think that their lives are pretty good, but we take the same population and we randomize them into 2 groups and give them 2 different kinds of treatments.
So you're not worried that the Vascular is not detecting a difference between CLTI and claudicants?
No.
You think we have to accept that from a disease-specific quality of life test?
Yeah, well, that's a problem. But as we go further and randomize the different cohorts, then I think that you get valid results. That's a problem. Your question is targeting a problem with all quality of life instruments. It's not specific for Vascular 6. But the randomization is the key.
Okay, so thank you, Pierre. Thank you so much.
Thank you.
Thank you.
I think we should go inside more about drug-eluting devices and mostly about drug-eluting stents and about the FemPop segment. So I call my friend and colleague Prakash Piquet, cardiologist from Manhattan. And Prakash, we are going to disappear with you.
Okay, I won't hold you up. Well, I want to thank the organizers for having me. It's a real honor to come here to Paris to speak to all of you. So my task today is to talk about resorbable scaffolding, the eternal promise. And I guess the question is whether I can say the promise is answered or not. I think it's going to be a difficult thing. But these are my disclosures. So I mean, what are the challenges we face? And all of us who are taking care of CLTI patients will face certain challenges. I mean, the majority of the times when we go in, as Sabine presented, we end up with flow-limiting dissections, which necessitate some sort of scaffolding to be able to handle this. Also, you will have a lot of heavily calcified burden, which will result in recoil and other things that will probably necessitate some sort of scaffold. And also the small diameters. We know that small diameter vessels don't do as well as larger vessels. So this is also a particular challenge. So we're always looking for maximal luminal gain. But also the biologic issues with restenosis and intimal hyperplasia have been already discussed, but these are also very relevant below the knee. So the other challenges is the discontinuation or the AT into the DP transition. We have to treat the outflow because the reason we're intervening on these patients is the ulcer, and we'd like to heal the ulcer. And also the same thing, you have preferential flow and which vessel to choose. So a lot of tremendous challenges that we're facing. So it ends up in what we have is multiple interventions over a 2-year period. For instance, this particular patient had 6 interventions over a 2-year period to finally heal the wound. The current landscape is not exciting. We have balloon angioplasty, and we know all the difficulties we have with balloon angioplasty. And we have atherectomy, which we use it more of a vessel prep. It's been studied as primary therapy, and we know that does not work, but however may have a role in challenging lesions. But we went through the whole gamut of the evolution of how we can treat this. Drug-coated balloons, well, we did the impact deep, and unfortunately, it failed to meet the primary endpoint, and there was a trend towards amputation. Whatever the flaws of the trial were, this kind of put to bed this particular balloon as a treatment for below the knee. BioLex 2, again, failed to meet the primary endpoint, but there were no safety concerns, which were encouraging, but however, we did not achieve our goal of the primary endpoint. And then when you look at other primary endpoints, the safety endpoint, there was no difference between DCB and PTA at 30 days. The efficacy endpoint, however, was non-significant. Now, what about stenting? So we said, well, maybe recoil is playing the role and paclitaxel-coated balloons are not the answer. So when we did this, we did the Saval study, and again, we were faced with disappointment, again, with no difference in primary patency. And thereby, what happened is we started to turning back to the old drug-eluting stents. And we said, well, we have a plethora of trials. Achilles, which was randomized versus PTA, Ideas, Destiny, and UConn. All of them showed, again, best patency results in the BTK space. The problem with all of these is that you had to deal with the scaffold when restenosis occurred, and as Sabine suggested, there was some crush in these proximal lesions, which made reintervention much more difficult for all of us. And if these patients ever needed a surgical bypass, it also became very, very difficult as you were dealing with a mechanical scaffold. So again, potential limitations of these permanent implants, even though DS probably has up to now the best-in-class data, although in America it is not FDA approved for below the knee, is in-stent restenosis, reintervention implications, and loss of vessel as a potential bypass target, and of course stent creep, which is the late restenosis. This led to the evolution of the drug-eluting resorbable scaffold concept. So what this does is it inhibits the restenotic cascade. It provides a scaffold to minimize recoil, which is another battle that we face. And the beauty is, theoretically, it's temporary, it's gone, and you have a patent vessel. So the currently one scaffold that's FDA approved is the Esprit BTK resorbable scaffold. It is 100% PLLA, very thin strut thickness. This is not similar to the coronary absorbed stent, which was 1.5 or 150 microns. And the coating is obviously uses everolimus. So the beauty is this scaffold can be placed and will be gone theoretically after exerting its effect. Now, the trial is the LIFE BTK multi-center randomized center trial, which we were privileged to be part of. And as you know, the 1-year results have been published, as have the 2- and 3-year results, which have just recently been published in circulation. And just to keep in time, the beauty was the composite effect of the limb salvage and primary patency 3 years was statistically significant in the DRS arm as compared to the PTA arm. This is the first trial that showed efficacy of an implant or of a product that was approved, that was tested for below the knee, that actually showed efficacy over PTA with an absolute difference of 23%. The late DRS failures were primarily asymptomatic restenosis by duplex. The target lesion revascularization was also significantly decreased, and this actually led to the approval of this particular scaffold. Now, it spurred on a new era of research into these resorbable scaffolds. Now you have the Magnitude Artery Vascular, which is the Elite BTK trial, which has just started in the US, 26 patients as of 10:30, and the Motive with Riva Medical, which was just completed. We're excited to see the data at the 12-month presentation at Charing Cross in 2026. But we already have results from the Motive trial. Dr. Buziers, who was here, will again discuss this at length, but clearly in the post-market study, it showed a primary patency of 80% at 36 months, freedom from TLR at 93%, and an excellent limb salvage and technical success, though albeit it is a registry. Now, this particular scaffold is exciting compared to the Esprit BTK, because you can actually see the scaffold and it comes in longer lengths. Part of the limits of the Esprit BTK is the longest length is the 38 millimeters that's available, and obviously the visibility of the scaffold is very, very low. As far as the technology behind the Motive, it's a proprietary Tyrocore resorbable polymer drug structure with sirolimus drug elution. And the beauty here is that there's iodinization of this to allow you to see it on the fluoro, which is very challengeable with the current Esprit stent. And if you look at this now, the average lesions, our diameters are pretty much the same, 2.5 to 4.25 here. It was 3.75 with the Esprit. But then you can see here that the scaffold can be expanded up to 4.5, and you can see the visibility of the scaffold here very, very clearly. You can see the Absorb, which is the coronary on the left, which is, again, no longer produced. And that's pretty much how the Esprit BTK scaffold actually looks. Motive, as you can see here, and then you can see DES. So it's much more visible when you re-intervene and also when you do ultrasounds to be able to see these lesions. The Elite BTK trial, again, the Magnitude Artery Vascular scaffold, the first in human Resolve 1 was completed in Europe. The ID is started in the US. And this basically is a PLA, but it's resorbable, but it's incredibly flexible. You can see the PDLA provides sustained drug elution to maximize the long-term patency, and the beauty here is it actually is much more flexible than the other scaffolds, which tend to break if you do this type of activity with them. So yeah, it's very important to see that the actual flexibility may play a role in this particular one. Whoops, how do I go back here? Maybe the other way. I apologize. Am I going backwards or forward? Oh boy. Okay. So the problem with these bioresorbable scaffolds is that our lesions aren't proximal lesions. They're mid, they're distal, they're inframalleolar, and we don't have a solution for that. So if you start putting anything below 10 centimeters above the ankle, what will happen is you will go ahead and have strut fractures or stent or scaffold fractures. So the issue is what about challenging lesions? Like Koen said, what about the lesions that we deal with real world? Well, heavily calcified lesions, complete occlusions, lesions longer than 44 millimeters, which was the average lesion length in the Esprit BTK trial, or distal tibial and ankle lesions. Well, according to the authors of the Life BTK study, they said, we did not put a prohibition on degree of calcium in the Life BTK. Approximately 1/3 were moderate to severe calcium, and we had about 22% CTOs. But I can tell you, as Dr. DeLuz said, that in these inclusion-exclusion criteria, vessel prep was just associated with just balloon angioplasty. So and I know, when we're dealing with complex tibial lesions, balloon angioplasty is not adequate vessel prep. So this is an issue. And I think we're going to learn more as we have real-world experience with these PLLA scaffolds to see how they respond to more complex lesions. And then you can see lesion length is an issue with mean lesion length of only 44 millimeters, and also Rutherford class. Even though there was a smattering of Rutherford 5, majority of the patients were Rutherford 4. So, well, does this lead to complete wound healing? Yes, we may have patency and reduction in TLR, but what about the wounds? The amputation rates were low, but these were also smaller wounds and not necessarily wounds that were very, very large. Now, what about challenging lesions? Lesions longer than 44 millimeters. The authors will tell you that, hey, you know what? The PLNA scaffold did well in both short, medium, and long lesions. And the final thought I'd want to leave you with is, how do you use this given the cost? If you look at DRS as primary therapy, you're talking about full lesion coverage and avoidance of geographic miss. And as you can see, that is what would probably result in the best patency with the DRS. However, how do we decide this, and what are the cost implications? There are technical issues of how we stent this. Do we overlap it? Do we not overlap it? And how do we do with vessel mismatch? Less than 2.5 millimeters below, 3.5 above. How do we match the DRS, and how do we deal with this? And this is going to be an issue. And most importantly, distal third of the lower leg and inframalleolar disease, and finally, information on wound healing. So in conclusion, I mean, we're all very excited about the 3-year results of the Life BTK study. I mean, it argues for a broad clinical expansion, and we're getting much more experience with it in the States since we got a little head start. But however, you know, it's important to remember that even though it's paved the way for additional investment, we have a lot of unanswered questions. Spot lesion versus full lesion coverage, ankle and inframalleolar interventions, complex lesions, and of course, more complex ulcers and Rutherford class. I thank you for the opportunity.
Fantastic, PK. Thank you very much for this great talk. Are there who in the audience, and meanwhile we have a quite good audience, so who is using in his or her daily practice resorbable scaffold technology today? 1, 2, 3, 4. PK, 4 people. So the other people, why you are not using it? Is it too expensive? Are you a non-believer? Is it not available? What are the main drivers there? Please. Not available.
Not available.
More comments? Too expensive. More? Not available. Everybody is a believer. I'm a non-believer.
That's what I wanted to ask. The next question is,
I'm a non-believer. I mean, I don't know the audience here, but when I go back to Dendermonde, I don't see lesions of 38 millimeter in my CLTI below the knee patients. You all see these kind of lesions?
You know, this is why I brought that point up. I mean, as a randomized controlled trial, as you know, the goal was FDA approval. You can say the protocol was sort of manipulated to have that approval possible. They did want to include lesions up to 177 millimeters, but because of the extensive exclusion criteria, those patients obviously did not make the.
Prakash, I think Sabine wants to make a comment.
Yes. Sabine.
I think we do have lesions where it's really useful, like especially at the origin of the below the knee arteries. You see massive recoil sometimes in there. And just to stabilize this recoil, to get a really good flow downwards, maybe to open up the microcirculation, I think it's really helpful, but we don't know. Yeah.
And also, the one comment I want to make is the actual resistance to recoil, or the radial strength of the device, is equivalent, if not superior, to the Xience scaffold. So don't think just because you have a resorbable scaffold that you don't have any resistance to recoil or crush resistance.
It could be a good combination, synthesis between the full maquette jacket and leaving nothing behind.
Yeah.
Jan, look at this fantastic image there. 2 eminent professors of France sitting together. So I think we need to join them. I think we need to join them. Thank you very much, PK.
It's a pleasure. Thank you.